Welcome to the Thyroid Podcast, where we bring together a multidisciplinary team of experts from Medcare Hospital Safa's Thyroid Clinic to make thyroid care easier to understand. In each episode, we explore important thyroid topics from different experts' perspectives, so patients can better understand their journey, all under one roof. Today we have Dr. Ghaida, Dr. Vanesha, and Dr. Momena. Today's topic to discuss is why a team approach matters in thyroid care.
Thyroid disease really, it sits at the intersection of these multiple specialties. So you really need the cooperation and collaboration between all the specialists. You need the endocrinologist, you need the radiologist, pathologist, the surgeon, and at times even the oncologist and the nuclear medicine specialist. So when a patient with a particular thyroid condition arrives in the clinic, of course, we take a detailed history, we examine the patient, and depending on what the condition is, we decide what the next step is going to be. Are we going to send them for radiology? We're doing a blood test, of course, and then from then on, we have to make, at the end of the day, an accurate diagnosis which guides our approach. So, let me give you an example, which is a very common example that requires this kind of collaboration between the different specialties. A patient, for example, presenting with a neck mass, with a swelling in the neck. Automatically, these patients will require, after taking a proper history and a physical exam, will need a blood test, and then we need to refer them to Dr. Momena, to the radiology department, where they can have an ultrasound scan. And depending on what Dr. Momena gives us in return in her report and how she characterizes the nodule, based on her report, we take the next step of action, which may require Dr. Vanesha coming in and doing a biopsy for us. And then depending on the results of the biopsy, sometimes the patients land in Dr. Vanesha's clinic where they'll need some surgical treatment.
I think most patients, when they come in with something in their neck, it's one of the sensitive areas in the body. And it's scary for the patient. Absolutely. The first thought they have is cancer. I see a lot of that phobia in most of my patients. True. And our effort goes into explaining to them that nothing is diagnosed yet. There are so many possibilities and not the first being cancer at all. So, like she said, they would do blood tests, they would try to figure out if there is a medical reason for what's happened, and add to it with the ultrasound being done by Dr. Momena Radiology, which gives us a lot of information about each nodule, helps us to categorize. There is this categorizing system called TIRADS, which she'll be able to tell us better about. And based on that, we will guide the next step. The next step could be a biopsy, could be just follow-up as well. It doesn't mean that even biopsy scares a patient, because a needle in the neck is not easy. I'm sure she faces a lot of patients who tell her, do I really need one? A lot of patients come and ask me, is it going to hurt? So lying down in that position with your neck exposed, a needle coming in partly seen, it's not pleasant. So we try to do things together and try to limit the invasiveness as much as possible, without compromising any safety or missing a diagnosis for a patient. Again, when it comes to a surgery, if the patient really needs it, of course we have to do it, but we also have to tell the patient that they need not imagine the worst at the first instance. Also, it's been a lot of changes over the years. Now, 10 years ago, thyroid surgery would mean definite hoarseness of voice probably, even though nerves can be identified by vision, by dissection. Now we have machines, we have things which help us avoid even going near the nerve, so the hoarseness is almost nil. Even preserving the parathyroid glands, which are glands near the thyroid, is easier because of parathyroid detectors. So things have advanced so much that it need not be a scary surgery anymore. Also with expert radiology care, we get such amazing information on an ultrasound. We get amazing guidance for a biopsy, that things can be done fast without several pricks. I think we can hear from Dr. Momena about this.
From the radiological point of view, when we receive the patients from Dr. Ghaida or the endocrinologist clinic, we have to do the simple and easy and most reliable ultrasound, which will tell us a lot about the thyroid gland, the size of the thyroid gland, the consistency, the vascularity in it, how's the thyroid tissue going on, what's going on inside it, how the nodules are they solid nodules, cystic nodules, the size of them, and so much information about them, where we put them in the most universal diagram or the system of reading, which we call it TIRAS system, where we categorize these nodules into 5 categories according to the specific points they are taking. And then again, according to the size of each category, we will decide either to follow up these nodules or to biopsy them. And again, the biopsy is also easier than the patient imagination. We always tell them it's like blood sample taking one. That's reassure them, and it's a very quick technique, and we are not needing it for each patient, only for specific cases, even for the high categorized nodules. So this is
Dr. Vanesha and Dr. Momena have highlighted beautifully the journey of the patient who comes initially they're super anxious, having seen a lump in the neck, and the first thing they think of is cancer, although the majority of these lumps in the neck are really benign nodules. So thyroid nodules, for example, they're extremely common. If you were to do an ultrasound, Dr. Momena were to do an ultrasound for people walking down the street, about 60-70% of them will have thyroid nodules. And the majority of these nodules, about 90% of them, are benign nodules. Yes. We don't need to do much after confirming that they are benign. All we do is just we keep surveying them, following them up with regular ultrasound at intervals. And the minority, which is no more than 5-10% of these nodules, turn out to be malignant and they need surgery. Even the surgery, as Dr. Vanesha highlighted, has become very conservative in the recent years. So most of the time we don't even need to remove the whole thyroid. We need to remove just half of it maybe.
Yes.
And leaves the patient really with the much lower risk of complications.